Hi, everyone. This is Bashar Qumseya. I'm the chair of the Standards of Practice Committee. It's my pleasure to be here today with my good friend, Kohli. Div is at Providence Sacred Heart in Washington, and he and Stu Amitow at the University of Minnesota were the lead authors of our most recent guideline on the management of post-liver transplant strictures. Div, thank you for being here.
Thank you, Bashar, for having me, and thank you also for your guidance, and to you and the entire SOP committee for making this happen. It was a pleasure to work with you all.
Thank you so much. I think this guideline touches on a very important topic that affects a lot of us who work specifically in centers that have or see liver transplant patients quite often. I know, for example, at our center, we do quite a lot of post-liver transplant strictures. And what we try to do with this guideline is to provide some practical evidence-based guidance for the practicing endoscopist gastroenterologist to decide what to do and how to do it, and reviewing all the evidence. I want to remind the audience that we now, all of our grade guidelines are published in two documents. One is a document summary, which summarizes the evidence and the recommendation. And the other one is a methodology document, which details all the methodology that we use for this, which is quite extensive. And it took about, maybe 2 years to have this completed, correct?
Yeah, it took a lot of time. There was a lot of literature to review. And, we wanted to make sure that we got all the best evidence.
Excellent, excellent. So I invite you all to review the evidence in detail. And as always, if you have any questions, please feel free to reach out to us. You can find our contact information online and on the publication itself. Without further ado, Div, we decided to do this differently today. We are going to discuss a clinical vignette and use the clinical vignette to maybe help answer some of the questions using the most recent guidelines, okay?
Sure.
All right, so here's the presentation. You have a 55-year-old white male with a history of hypertension and diabetes and alcohol abuse, who is status post-liver transplant in March of last year. He was seen for follow-up in the liver transplant clinic and was found to have some abnormal LFTs. He's otherwise asymptomatic. His vital signs are stable and his physical exam is normal post-transplant. His liver tests include an ALT of 102, AST of 99, alkaline phosphatase of 300, total bilirubin of 2.1. Again, no fevers and a normal white count. And the question I have for you is, based on our most recent guidelines, what should be our next step?
Sure. So essentially, this is a liver transplant recipient with elevated liver enzymes, but no evidence of cholangitis. So no fevers and no abdominal pain, no elevated white count. So that's a good thing. We have time on our hands to figure out what could be going on. The fact that the liver enzymes are elevated by itself is not a diagnostic of anything. Liver enzymes could be elevated from the underlying liver disease or the fact that the patient has just had a liver transplant. The most common complication after a transplant is actually a post-transplant stricture. So for this patient, because we have a clinical suspicion for a liver transplant-related stricture, the guideline, our current guideline actually recommends getting an MRCP instead of going directly to an ERCP. Going to an ERCP directly would be feasible only if there was cholangitis and we had features of that. So in this situation, we actually had a review of about 20 studies that looked at the diagnostic accuracy of all modalities. So just elevation in liver enzymes, an ultrasound, going directly to ERCP or MRCP. So if you compare all of these, the best diagnostic accuracy is for the MRCP. It is a highly sensitive, a highly specific test. It has excellent diagnostic accuracy, and it has very minimal risk of harm. So that would be the next step. Talk to the patient, talk to the transplant team, and my suggestion would be to get an MRCP for the patient.
Excellent, excellent. I also want to note, Div, as you mentioned, sometimes these LFTs can be minimally elevated in these post-transplant patients. normally when you see non-transplant patients who have strictures, I find them, at least anecdotally, to have more elevation, specifically of bilirubin than transaminases. And unlike these patients with liver transplant, sometimes minimal elevation, which may not seem like a lot, is indicative of a stricture. Is that your experience as well?
That's exactly true. And that's also what the data show, that the liver enzymes by themselves do not rule in or rule out a stricture. They're just a guide for us to assess more deeply.
Okay, excellent. So as you mentioned, this is mentioned in our third recommendation in liver transplant recipients with suspected biliary strictures. The ASGE suggests an MRCP as a diagnostic test. Are there times when you would not get an MRCP and you would go directly to having the ERCP?
Right. Yeah. So in case a patient would come in with jaundice and a fever, or had bacteremia, or a significantly elevated white count, in that case, the concern would be that there is a stricture and that is causing cholangitis. In those situations, waiting for an MRCP is not necessary. These are immunosuppressed patients in whom source control is crucial. So in these patients, if you have cholangitis, go directly to ERCP.
Exactly. So if it's an elective presentation, somebody's not cholangitic, then adding an MRCP is very helpful. If otherwise there is a cholangitis presentation, then MRCP may not add much, because regardless of what you find, you might still proceed with an ERCP. Excellent. So for our case, we go ahead and discuss it with yourself, and you tell us get an MRCP. So we get an MRCP, and the reading said suspected anastomotic stricture cannot be ruled out. What should we do about this? Tell us, how would you proceed at this point in time?
Well, so I think the first thing I would do is review the images myself. While we trust our radiologists, it's a good idea to review, see what the anatomy is like. Also talk to the patient, the transplant hepatology team, that there is a concern for a post-transplant stricture. It looks like it's at the anastomosis. The next step would be to do an ERCP. Our guideline actually assesses this question, that the first step, should that be an ERCP or an IR-guided PTBD, which is the percutaneous transhepatic biliary drainage done by the radiology team. So our guideline assessed the data. We looked at the published studies. And interestingly enough, we actually had a patient representative on this, because we want to make sure that the patient's voice is heard as well. The data suggests that the ERCP is actually a safer and a better therapeutic procedure compared to a PTBD. For one, the risk of failure is lower. You don't have any drains that are sticking outside with the ERCP. And again, most importantly, our patient representative also mentioned that it's difficult for our patients to manage these drains at home. They've already undergone a major surgery. These drains can cause pain. They can cause discomfort. These can also get dislodged. So I think the next step for this patient, after discussing with the team, reviewing the images, would be to go ahead and perform an ERCP as the first line of therapy.
All right, excellent, which gets me to the next point. So the question that you tried to answer in this guideline, which is the first question, is should you do PTBD or percutaneous drainage versus ERCP? It's interesting also that a lot of the data, we had clear data from a large cohort study that showed worsening rate of rejection or failure of the transplant if you had PTBD. Can you tell us about that?
Right, yeah. So the data are from a large nationwide study that looked at patients who had an ERCP or PTBD. So the patients who had PTBD had a higher risk of allograft dysfunction, allograft failure. There's a higher risk that those patients who are getting the IR-guided modalities may be at a higher risk for requiring a new liver transplant or having a failure of their allograft. The exact mechanism of this is not certain. It is a possibility that perhaps the risk of failure is higher with IR-guided procedures. So for all these reasons and the ones that are enumerated earlier, it's a lot better for the patients to get the ERCP done as the first line of therapy. That is also my practice. I think that's also the practice at most major transplant centers.
Excellent. So the idea of the evidence here suggesting that we should proceed with ERCP, not PTBD. Are there scenarios when percutaneous drainage is more appropriate and should be pursued instead of ERCP?
Yes, most certainly. So, again, none of these things are absolute. We have to tailor our interventions based on what is in the best interest of the patient. So PTBD is preferred in case endoscopic access is difficult. So specifically patients who've had a Roux-en-Y anatomy, in those cases, getting the endoscope down to the level of the bile duct can be a challenge. In those patients, a PTBD would be the more appropriate thing. Or sometimes it's just very difficult to cannulate the bile duct. All these procedures have their risk of failure. So we always tailor our interventions to what is in the best interest of the patient.
Also, if a patient is too sick to undergo endoscopy,
right,
they're hemodynamically unstable or they have cardiopulmonary reasons why they cannot undergo sedation, the guideline notes that in these patients, PTBD may be preferred because they use minimal sedation.
That's correct. That's very true.
To what we need to do an ERCP. Excellent. So we decided to proceed with an ERCP. And the real question is, which is an important question, is what should we do about the biliary stricture? The main question we wanted to address is, should we use covered self-expandable metal stents, or should we use plastic stents? And if we do, why and why not? Can you tell us what we found about that?
Sure. So this is again something that we've addressed in our guideline. And overall, for anastomotic biliary strictures, the ASGE is suggesting the use of covered metal stents. Now, there are some caveats to keep in mind. Again, as I mentioned earlier, the first thing to do is to assess the imaging by oneself to see where is the location of the stricture, how many strictures are present. If there is a single stricture at the anastomosis and there is some distance between that stricture and the hilum, in those patients, a covered metal stent makes a lot more sense. These are stents that will last longer, unlikely to get clogged. On the other hand, there are some times where a covered metal stent may not be appropriate, especially if you have multiple strictures in different ducts, or if it is not safe to put in a covered metal stent. As always, it's important to discuss these options with the patient ahead of time, once you know where the stricture is, how tight it is, because patients must also know there's also a risk of migration of the covered metal stent. So it's always a decision-making that requires input from multiple stakeholders and multiple providers.
Exactly. I think you made the key point here that the guideline here found that it is better to place self-expandable metal stents, covered stents. You get better outcomes. You're less likely to come back, better structural resolution. However, you cannot place them on everybody, as you said, because of the location. If you do decide to put plastic stents, what kind of stents should you use? What size? One, more than one? What did we find about that?
So typically multiple plastic stents are better than just a single one. Sometimes the strictures are very tight, but our preference should be to use multiple plastic stents. There is no one size fit all policy in terms of the stent size. Typically 8.5 or 10 French stents have been used. There are data regarding the safety of all of these. But you have to tailor the type of stent, the size of the stent, and the length of the stent based on the anatomy of the stricture. The care should be taken that the length of the stent is such that it goes above the stricture. And if you have more than one stricture in a different duct, then make sure both strictures or all the strictures are stented to the best of your ability.
Excellent. So the idea is to have the bigger stents, the better, right? So if you can place multiple 10 French stents, then you should try to do that. Perfectly, many of the studies did that. We didn't find a lot of studies placing one stent. Usually,
For plastic stents, you want to place multiple plastic stents. For the metal stent, one single stent will suffice.
Anecdotally, as a discussion point, what's the most number of stents you put in one patient?
I think about 6.
Okay, you beat my record. I had 5. So
Well,
that's good.
again, as we said, it just depends on what the patients need. Sometimes for intrahepatic strictures, you just end up putting quite a lot more and you hope and do the best you can.
Yeah. A good point to remind everybody, if you are placing a stent, always remember to talk to the patient before and after, talk to the family, document it, and make sure you order a follow-up, because these stents are not permanent. While this is evident to us, sometimes this is not evident to patients, because patients think about stents, they think about heart stents or vascular stents, which are not replaceable and do not get removed. So it's important to educate your patients, document it, and make sure you are safe about using stents. Somebody could go and not come back and have cholangitis. Now, this is less likely in somebody with transplant, because usually they have good follow-up. But this is just a point of caution for our endoscopists in general. All right, excellent. What do you think about, I had a situation similar to this recently, where the structure was high up, but still away enough from the hilum that I could place a stent. But if I put in the longest covered stent we have, which is 10 centimeters long, it would not be transpapular. We did not discuss this too much in the guideline. What are your thoughts about that?
So intraductal versus transpapillary stents, right? You could place an intraductal stent. There is some risk, though, that these stents, as you mentioned earlier, they're not meant to last forever. These stents have to come out. So I think that sometimes is the issue. Removing an intraductal stent can be a challenge sometimes. It's doable for sure. You have to make sure that you have an adequate sphincterotomy. You've done a decent sphincteroplasty that the stent can come out. This is just some risk to keep in mind, that there is some risk. It requires obviously expertise while placing these stents. So there's not much data. Anecdotally, I would say it's a challenge. It can be done. It's not the standard of care, though.
Yeah. I also want to point out, you bring up a good point, that we, obviously you, having been on the standards of practice now, and we haven't been for 7 years, work on multiple guidelines at the same time. We had a guideline on post-ERCP pancreatitis. And we did notice in the literature that placing metal stents is actually a risk for post-ERCP pancreatitis. So you want to be cautious of that. There's not a lot of data, and this is not the guideline for it, but if you're placing a metal stent, to discuss that risk with the patient, make sure you use endomethacin, make sure you have a decent sphincterotomy to minimize the risk of compression of the PD. I think those are all important considerations. Also, we are currently working on a guideline about patients who do not have normal anatomy, like we said, and maybe they have one Y or another kind of anatomy that makes doing a straight ERCP difficult. And there are different endoscopic approaches to deal with that. This guideline did not deal with these patients. Specifically, we dealt with patients who do not have altered anatomy as far as the digestive tract for this guideline. But we do have another guideline coming up on that topic. So please stay posted for our audience. Okay, excellent. I think the last question we want to finish up with, which is a question that took a lot of discussion on the panel. Should you use antibiotics in everybody who is liver transplant patients? What did we find, and what was our final recommendation, and what would you do?
So the role of antibiotics in endoscopy in general has been evolving. Earlier, the recommendation was that everybody who gets an ERCP should get antibiotics. Our last guideline suggested use of antibiotics during ERCP in liver transplant patients. So as more data has come out, we found more studies, and it turns out that the quality of evidence is not really overwhelming. We had only 2 studies, both from liver transplant centers, one from Indiana, I think one was from Virginia Commonwealth University. And both these studies basically demonstrated that the risk of infections is relatively low, and the antibiotics don't really impact much. But there is one big caveat, and that is the ERCP actually has to succeed in making sure that you have adequate drainage. If you don't have adequate drainage, if your stent has failed or your ability to inject contrast is not matched with your ability to drain that, those patients are at risk for infectious complications. So in our guideline, we've actually tried to clarify this a little bit, that there should be an individualized approach to what the patient has. In case the patient has multiple strictures which we've not been able to stent, or we cannot be certain that adequate drainage has been achieved, then it is a good idea to administer antibiotics. For patients in whom this has not been clarified, or in patients in whom you actually do have excellent drainage, then it's a matter of choice and discussion between the physician, the endoscopist, and the patient. Remember, antibiotics also have their own risk of adverse outcomes. Ciprofloxacin, which is very frequently used in these patients, can prolong the QTC. We also have to be good stewards of using antibiotics. So that is a discussion that should be had. In general, my preference is I hedge towards giving antibiotics if there is no adequate drainage. But if, on the other hand, let's say I have an anastomotic stricture, I have excellent drainage after I've put in a fully covered metal stent, then I hedge towards not giving antibiotics. I'm very certain that my procedure has succeeded. I'm very certain that all the contrast is draining out. In that case, I'm okay. But again, this is a discussion you should always have with your transplant team, your transplant hepatologist, and the patient. Then I also advise the patient to be mindful of what are the adverse outcomes that can occur. So I tell them that if you have a fever, don't wait, just come to the ER directly or contact us right away. So there is a little bit of nuance to this. And again, we are trying to follow where the data are leading us.
Excellent. Yeah, excellent. So not a lot of data, as you said. A lot of people do use antibiotics. And I think we said, if you do not achieve biliary drainage, or if it's technically difficult, or there's multiple strictures or failure of stenting, then those are definitely indications that you should give antibiotics. Normally, we suggest giving antibiotics perioperatively during the procedure, maybe or shortly after, and then maybe for a couple of days. Again, limited data on those suggestions and very low quality of evidence overall. But as you said, given antibiotics is not risk-free. In fact, I remember vividly, and I shared this with you, I had a patient who coded after the procedure because we gave him ciprofloxacin. Unfortunately, he did not do very well. So those antibiotics do come with some risks. They're certainly not risk-free. And please be cognizant of that when you decide to give antibiotics. And please give antibiotics if they are needed. But not everybody automatically requires antibiotics. All right, Dev. Well, I do want to say that actually, when you first joined the SOP, this was kind of your idea to talk about this guideline. So I want to thank you for doing that. You worked very hard along with Stu Amitabh, who also worked very hard on this and couldn't join us today. So I want to thank you all. Of course, thank you so much for all the amazing members of the Standards of Practice Committee for all they do. We hope that you guys are enjoying these author interviews about these guidelines. Our hope is that you can use our guidelines in your daily practice to improve your outcomes, standardize your practice. And we know that implementing evidence-based guidelines can have good outcomes for the patients. So all our guidelines are published in GIE, and you can access all of them for free. If you do not have access to GIE, if you go to the ASGE website and click on guidelines, you will find all of our guidelines free for access for everybody with no subscription. So again, thank you so much, Div, for doing this. I really enjoyed working with you. I know you're working on another guideline on PEG tubes. So everybody stay tuned for that. Hopefully we'll get that done in the near future. And if you have any questions, you can contact us. My contact information is on all of our guidelines, and the ASGE contact information is on the website. Thank you so much, and feel free to call us or to email us if you have any questions or any topics that you would like us to address as guidelines. And have a wonderful day.
Thank you, Bashar, for hosting, and thank you for your leadership. We appreciate it.
All right. Thank you so much, Dave. You have a good day.